Hello, welcome back. Hope you all enjoyed your lunch. Right, now for this part of the study, for this part of the talk, I'm hoping to go through the remaining studies and different modalities that we have available to us as radiologists. Obviously, as I said, it gets a bit more technically advanced. And I'll just start straight off with CT, which is also quite a good modality, but again, the main setback with CT is we're having to deal with radiation. But CT gives very good soft tissue and bone imaging. It's used CT is the workhorse for intracranial imaging. We also use CT as in ultrasound to guide procedures. With CT, sometimes it's necessary to give intravenous and oral contrast. But the limitations are stated already. Ionizing radiation, that for contrast, you can sometimes have reactions to the contrast, allergic reactions. So this is the sort of images that you're presented with in CT. And with CT, where in ultrasound we talk about echogenicities, in CT we talk about densities. So, this is just an axial section through a patient's brain. And the bright area there is obviously the bone, which is high density, is shown as bright on CT, and air in the mastoid and sphenoid sinuses is shown as low density or darkness. And some of you may have picked this out already. Why is there air here? There shouldn't be any air. So you obviously have air in the sinuses sometimes. There shouldn't be any air within the brain. And this patient seriously sustained trauma. And whenever you see air in the brain, you need to go and look for the fracture, because obviously the brain intracranial cavity is communicating with the outside. And that's just the next slide up. See a lot more air in the patient's brain. The patient had a base of skull fracture. I thought I'd shown it on there, but unfortunately it's not on this image. Right, now with the densities, occasionally the densities may be very similar. So in this patient, for instance, that all looks very gray. But then if you look closely, sometimes the gray areas there may be different from the gray there. This is a patient with, does anybody know what this condition is? Very important to recognize this, because this patient is actually bleeding into the brain, but the blood is sort of, if you like, trickling into the one of the spaces in the brain very, very slowly, and therefore you're not getting time for it to show the classical density that blood sometimes shows. So this is a subdural, subacute subdural hemorrhage in the brain, and sometimes it can be very, very subtle, as in this case, where the subdural hemorrhage is there and there as well. It's always important to make sure that the sulci go all the way to the end of the inner table of the skull. But MRI shows it a lot better. With MRI, obviously, you're not dealing with densities, just different signal intensities. A few more examples. I'd just like to sort of go through this quite quickly, just using this to demonstrate the densities. Now, acute fresh blood looks like that. So this is another patient bleeding into the brain, where you have increased density, this time in the sulci and in the fissures. And this is a case of subarachnoid hemorrhage. More different densities. This time the density is actually within the brain itself, and this is a patient with a brain tumor. We've given the patient some IV contrast, and the contrast is being taken up by the tumor preferentially. And you can see that tumors start to move, structures around, the ventricles are moved around. This is a meningioma. And it's not only high densities that we look for, we also look for low densities in CT. This patient is a very sharply marginated area of low density here. It's not a tumor because it's not pushing anything. And it conforms to a vascular territory within the brain. And a patient with an intracranial infarct presenting as a stroke would have this appearance. And sometimes a stroke may be old. And this, for instance, this one is the region of the posterior cerebral artery. Other important uses for for CT is in the chest, where in this case, just giving the patient contrast. The contrast is filling the mediastinal vessels, but there's a filling defect there. And this is clearly a case of a very large pulmonary embolus. You can confirm this with nuclear medicine. You can see in this case that the side that was not perfused, that is the right side of the lung. That is obviously a posterior image. The right side of the lung is not perfused and shows no perfusion on the nuclear medicine study. Again, multimodality imaging coming in there. Different densities. You see, this obviously a very low density, but you can tell that just within that low density, it's not as low as the air within the bowel or the air outside. The air is not, this is slightly denser than the air, and that's fat. So the patient has fat, but in addition, this same swelling here has some calcium in it. And CT is certainly the modality to use to diagnose this particular condition, which is an ovarian dermoid cyst. Contains different densities. Now, we've moved on with CT a bit, and actually I understand that here in Kolebu you have the 360 slice CT scan, which, so I think there aren't many developed hospitals that even have that much. Most departments, a 16 slice or beyond will be much useful for doing most of the work in the department. I'll try not to go into the other technical issues of CT, and I think we've seen enough images there. I'm going to leave a copy of my presentation to you as slides. I could probably just quickly go through some of these important images. CT is not only used for axial imaging, but these days we can reconstruct it in a coronal plane, as in this case. Part of the ribs are missing here in this patient, very elegantly demonstrated on this coronal CT scan, the patient with a pancreas tumor. And then another coronal image showing the hernia. It increased. I just made that a little bigger to show the hernia on that side. We can get volume rendering in CT. We can do 3D. Lots of 3D images, and we can show that for you later. And virtual colonoscopy, where we reconstruct the images in a 3D fashion again and add movement so that we can look through the bowel. And 3D reconstruction of the bone. This is very useful in patients who have major trauma to look at the cervical spine in a 3D format. CT being used to perform procedures, take biopsies. This patient, we're just about to perform a biopsy on this mass here. So we've put the markers on, and then in a minute you see the needle coming through. We can see the markers on the skin, so we know exactly where we're coming. Straight down into the mass, take a sample, and get the tumor diagnosed. There we are. We're doing taking samples sometimes. Very small lesions can also be biopsied under the guidance of CT. Now MRI. MRI again is obviously much more advanced. It's obviously taking cross-sectional imaging to a whole different level. This time we're not using radiation. But we're using just the magnetic force to get our images. And in this patient, in this setting, we also have to remember we're using very strong magnets. So if you're not careful, you may end up with a situation where if you have your magnets on, very strong magnets, a trolley has been left outside the MRI door. As soon as you open the door, the trolley flings straight into the strong magnetic field of the MRI scan. Just as well, there's no patient in here, so the patient will have been very severely injured. So what are the other contraindications for MRI? Patients with pacemakers, anything, magnetic, ferromagnetic material around the patient, foreign bodies in the patient's eyes, cochlear implants, some prostheses if they are ferromagnetic. If you are in any doubt, you should consult MRIsafety.com. It just has a big database of different structures that cannot be MRI'd, and different equipment. The other problems with CT is that because not many people like being in an enclosed space, you may have patients who cannot tolerate an MRI scan because of claustrophobia. And then when you are in an enclosed space for too long, you tend to move. And if you move, you're going to develop artifacts. Long waiting lists in the public sector. And the cost, obviously. All right, with MRI, we talk about signal. So just a quick recap. Ultrasound, we talk about echogenicity. CT scan, densities, MRI signal. So with MRI, we talk about signal intensity. So that would be a high intensity MRI, intermediate intensity, and then low intensity. Okay, and there's several things so-called low intensity, several things so-called high intensity. By far, fat is one thing that tissue that causes high intensity. In areas where you expect high intensity to be when it's not there, for instance, in this case, you'd expect the fat from the prevertebral tissue to carry on all the way up, but then in the place of the fat, there's this large soft tissue mass probably arising from one of the vertebrae, and that is a plasmacytoma. The danger there is that if this has extended into the spinal canal, it will compress the spinal cord. We can use flow phenomena in MRI, generate beautiful images like that. And this, again, we can use not flow this time, but fluid intensities to generate those sort of images. Does anybody know what this is? Okay, this is an MRCP. MRCP image showing a patient with a gallstone. We've seen gallstones before, but just several filling defects there. You see a very dilated warm bowel duct. That's just an ERCP to correlate the MRCP showed previously. Use MRI for different things. Functional MRI, as in this case, diffusion weighted imaging, MR spectroscopy can all be performed where different colors are assigned to different parts of the brain in an MRI scan. All right, now just coming to the end of the talk now, I'd like to just briefly go into interventional radiology, where this time radiologists are not just sitting in a place reading scans, but we're actually performing procedures. This is a case of a patient with a carotid body tumor, chemodectoma, where we've given contrast, put a contrast into catheter. We've put into the patient's blood vessels, given the patient a contrast just to show the blush from the tumor. And then we can then go in and embolize it. In this case, a patient with very, very dilated esophagus in the barium swallow. The narrowing is there. You can put in balloon to dilate the narrowing of patient's esophagus. There it is. There's demonstration of achalasia of the cardiac. The very narrow esophagus there is very dilated. Now what is this? Okay, this is a PET scan where this is actually the PET image. And now we're doing hybrid imaging where we're fusing different modalities. So a CT scan is fused with a PET image to give this hybrid image where we've superimposed the images there. So this gives us the anatomical data, that gives us the functional data, the patient with the lymphoma. And then the areas of brightness that we see, we can make it any color this time, not just densities or echogenicities. We just make this any color. And in this case, it's the bright areas as well, the areas of disease. This helps you to pick out abnormal lymph nodes in this case. So this is nuclear medicine, where in this case we give a patient an isotope. The isotope gets taken up by where the disease is, and the disease is shown up. The disease is shown up where the isotope is taken up, and then we use a gamma camera or a PET scanner to detect where the disease is. So with PET, we use different isotopes. With PET, we use F18 FDG, which is a glucose analog. So the F18 is actually the active part of the isotope, and the FDG is the glucose analog. And then there are lots of other different isotopes used for different procedures. Okay, we'll just skip that. Alright, so the beauty of PET is sometimes when you're looking at a CT scan image, for instance, there's a sort of things that you're not too certain whether they represent disease or not. For instance, a small lymph node here, it will be very easy to miss, but on a PET scan, you see how bright that shows up. The same patient showing the bright PET scan. And in the abdomen as well. Right now, so multimodality imaging, we're trying to move from the bottom of the mountain to the top of the mountain. We need different modalities to get to our goal. So just as an illustration, let's take this case where we've got a 52-year-old Mr. X, who's a smoker with a cough. His chest X-ray shows a lesion, which is not on his old films. So we proceed to staging CT scan. So that's his chest X-ray. This shows bulging hilar on both sides. They've gone for our CT scan, which shows the large mass there and some lymph nodes in the mediastinum. You can see when you go on image line, you also look at everything, make sure there are no destructive lesions or metastasis in the ribs. The lung window settings shows it quite well there. It's a large right hilar mass. So from there we'll go on multimodality imaging. We want to get to the top of the mountain. We're going to do a PET CT scan. That's our CT image with the mass. That is our PET image. And then that is the hybrid image where we fuse the PET and the CT scan. We show the large mass, no metastasis elsewhere. And same again, the same patient, that's the mass there in a coronal image. But unfortunately, the patient has another deposit there, which is in the adrenal gland. So this is stage 4 disease. And this is how we use multimodality imaging. So this has completely changed the management of the patient. Whereas if the tumor probably hadn't spread to the adrenal gland, we could just have gone for surgery just to remove the mass. Although that probably might, most doctors might probably not want to take such a big mass so close to the hilar mount, but it just sometimes allows you to decide management. So stage 4 disease patient is now not going to be surgically curable. We'll have to go for chemotherapy or radiotherapy. Right, in the second case, a 42-year-old female presents with dyspnea, no response to asthma therapy. CT shows a 2.7 centimeter intrabronchial lesion. So in this case, we have decided That's a tumor there. It's quite a small one. Again, one in the lung. We use then just a coronal image there. That's a tumor at the junction of the bifurcation of the left main bronchus. And we use octreotide this time as a nuclear medicine study to show the lesion. There's no other lesion outside that. This patient had a PET scan. This is still a octreotide scan. Show the lesion there. And we can see on this one that it's just a solitary image in the lung. It's a benign solitary mass in the lung. It's a benign lesion. After surgery, the patient is not going to need anything else. Surgery is going to be curable. Right, so just a few take-home messages. That imaging modalities are complementary to each other. They are not competitive. Because you've used you're not going to say that X-rays are always better in one case, or I only use CT scan. They always sort of complement each other. And we need to make the best use of available resources and equipment, and also bear in mind that cost implications need to be considered, and that we're obviously moving towards the era of molecular imaging, with PET-CT scan as probably leading as the next frontier in radiology. Any questions? Thank you very much for your attention.